Estamos acá con la doctora Silke, es la presidenta de Advisory Prostate Cancer y Consensus. Hoy estuvimos en la charla de cáncer de próstata en general. Dr. Silke, nice to meet you. It's a pleasure.
Hola.
The question is about the bicalutamide in my country, Ecuador. Is really used for the patient because they all new pills or RP. Just in few cases in my country, we can give it to a patient for the government because this kind of treatment is very expensive, and then less cheap is Abiraterona, almost 700 bucks per month. So what about you think we can keep using the bicalutamide in this case for the difficult to get the new RPs?
So I guess, like when we speak about the metastatic hormone sensitive setting,
Yes.
we have some older data adding bicalutamide like
Yes.
maximal androgen blockade. And we have seen about 5% increase in overall survival versus ADT alone.
Yes.
You know that with the newer
Yes.
Abiraterona, enzalutamide,
Yes.
apalutamide, darolutamide, the increase in survival is much
Yes.
better. So if you can get one of
Yes.
these RPs, it would be better. As we discussed, there is some data in the metastatic later setting that if you use Abiraterona,
Yes.
only a fourth of the dose, so 250 milligrams,
Yeah.
but given with food, you have very, very similar AUC of the drug in the blood than giving 1,000 fasting.
Yes.
So in that sense, maybe if that's an option, because also the Abiraterona is now generic,
Yes.
and in some countries you can get it very cheap,
Yes.
that you would give the 250 with food.
One pill per day.
One pill per day
With
with
fat
food,
food.
but that's important. With fat food or
Yes.
with food, there is the different trials, and that should work as well. So we have done a Lancet commission about prostate cancer,
Yes.
and this was one of the recommendations. If you can't afford the full dose of an RP,
Okay.
maybe you could discuss with some of your patients doing an orchiectomy instead of giving the LH-RH agonists or antagonists that are more expensive
Yes.
than doing an orchiectomy.
Right.
When you know that you do continuous ADT or have to do continuous ADT anyway,
Yes.
so you can spare some money by doing the intervention.
Yes.
And not giving for 8 years.
Yes.
We saw the data now, that it's now 8 years of LH-RH
Yes.
analogs, and that money that you don't spend
Spend
there,
in,
maybe give it for the one pill of
One pill.
Abi and give it with food.
Even the orchiectomy.
So you can think about that, because then you can make a good package for your patients,
Yes, that's
especially if they know or high volume disease. And again, we wrote all that in the Lancet Oncology Commission.
Yes.
The Lancet Commission on
Yes.
prostate cancer.
Uh-huh.
So maybe you can read there, because this was specifically also for low and low middle income countries.
About the cardiologic disease, 1 year ago, in each speech now is talking about for the cardiologist.
Yes.
It's a principal effect about giving the analog, in this case of this patient, the ADT. But we don't know if we can get the orchiectomy, give the patient the same risk, cardiologic risk. And different is about with the ADT, we can take off and don't give the patient call to the cardiologist to get continuous help with it.
So the thing is, I think, is very important, the collaboration with a good
Yes.
cardiologist,
Yes.
especially if the patient had already an event,
Yes,
like
that's
cardiologic event, right? So FP
First go to the cardiologist
Yes, right.
before you use.
and do an ECG. That's very cheap, but it's
I
worth
write in my
doing it.
head to
Right.
el cardiólogo sabe eso que en mi hospital lo hago.
Yeah, it's very
I do that.
important. Yeah, and in that sense, I think every form of hormonal treatment can have cardiological side effects. So it's always good to have this collaboration, and I think it gets more and more important because we're getting more
treatment for the patient.
Right, and we're getting also more and more successful with the treatment. So it's a good thing. Patients live longer, but now we have to look for the long-term side effects as well.
And the next question.
Also bone.
Thank you for this moment with the president. What about you think the antagonist? But this in case this is oral pills.
Yes, so
in that case, there's no issue cardiovascular.
No, there's also issues. Maybe a bit less. We don't know. There is, the data is not very clear. Like there was some hints that probably in patients who had already a cardiologic event, maybe the antagonists are a bit more safe. But I think they are, at least in a lot of countries, much more expensive than the agonists, or much more expensive than orchiectomy. So if you have to look also about the cost for society, you have to think a lot about that.
To get that money to the therapies.
Right.
Thank you very much, Mr. President. I invite you to Ecuador someday.
Oh, that would be nice. Yes. And I hope a lot of people from Ecuador are coming to APCC 2026 in the end of April. Thank you.
In this case, I'm a member from Society of Oncologist of Ecuador, and we are invited to go to Ecuador.
Nice. Oh, this is wonderful. I've never been to Ecuador, and I say hello to my friends in Ecuador.
We appreciate it. Thank you.
Thank you.